Optimization of peritoneal fluid and leukocyte collection in patients with endometriosis. Endometriosis is a gynecological disorder characterized by the growth of endometrial cells in extrauterine sites, mainly in the peritoneum and ovaries. The main symptoms are dysmenorrhea, pelvic pain, and dyspareunia. Furthermore, endometriosis is associated with an increased risk of infertility and ovarian cancer. The etiology of endometriosis remains unclear. However, the peritoneal immunological environment, especially macrophages, appear to play an important role in its development and maintenance. Nevertheless, there is a need to increase knowledge in this area. To this end, it is necessary to analyze peritoneal fluid samples, which are obtained by aspiration during laparoscopic surgery, and to perform peritoneal lavages in order to obtain more cells. Although there are many studies where these samples have been analyzed, most of them contain only a few vague and incomplete references to the method used to collect the samples. The main aim of this article is to provide a step-by-step description for peritoneal fluid and leukocyte collection in patients with endometriosis, to evaluate the suitability of the samples obtained for biomedical research, and to analyze the variables that can affect the efficiency of the procedure. For this, we recruited 103 patients with confirmed endometriosis from the Hospital Virgen de la Arrixaca in Murcia, Spain. We performed a video description, including technical recommendations for peritoneal fluid and leukocyte collection, and quantified the viable cells present in the samples. We also analyzed the effect of blood contamination, lavage volume, body mass index, hormonal treatment intake, and age on the amount and quality of the biological material collected. It is recommended to collect the samples within the first 10 minutes after the induction of anesthesia to avoid its negative impact on the results. We recommend using carbon dioxide to induce pneumoperitoneum, since it is highly soluble, pharmacologically inert, and has a high diffusion capacity. Abdominal temperature is also important. Insufflations of carbon dioxide should be done between 20 and 25 degrees under dry conditions. Lower temperatures could affect the immune peritoneal environment. For this reason, we recommend the use of thermal blankets to maintain the patient's body temperature and minimize changes. Finally, if hysteroscopy is necessary in the same procedure, the laparoscopic technique should be performed first to avoid blood contamination. Since there are no significant differences in the various entry routes, we use a Veress needle at the umbilical point or palmar point and begin carbon dioxide gas insufflation until achieving a maximum pressure of 18 to 20 millimeters of mercury. We introduce the main umbilical trocar, using a lens of 0 or 30 degrees with a fixed light intensity at 180 watts and 60% intensity, since strong light on the peritoneum can cause its desiccation. We insert a single accessory trocar of 5 mm into the left or right iliac fossa to minimize the risk of blood contamination of the samples. We inspect the abdominal cavity and then reduce the intra-abdominal pressure to 10 to 12 millimeters of mercury and position the patient in the Trendelenburg position at 15 to 30 degrees, which is maintained during sample collection. After that, we used an endoscopic aspirator and a sterile syringe to aspirate any peritoneal fluid present. The target areas for peritoneal fluid collection are the pouch of Douglas and the vesicouterine space. Fluids contaminated with visible blood must be rejected. After peritoneal fluid aspiration, the peritoneal surfaces must be washed with normal sterile saline solution, moving it carefully through the parietal and visceral peritoneum, helping with manual movements over the patient's abdomen. We recommend waiting at least 30 seconds after mobilization of the sterile saline solution before its aspiration. Since the amount of saline solution used for peritoneal lavages is a variable to analyze, the volume used in this protocol will be discussed later. Peritoneal fluid and lavages should be stored separately and kept at 4 degrees to minimize its tampering. The samples should be refrigerated within the first 20 minutes after collection in order to avoid macrophages aggregation and adhesion to the plastic container. Once at the laboratory, the appearance of the samples should be checked and then immediately placed on wet ice, Then they are centrifugated in order to separate the supernatant from the cell portion. After that, cell concentration is determined using a Neubauer hemocytometer chamber by light microscopy, discarding the dead cells by trypan blue exclusion test. Despite some authors' indications that the volume of peritoneal fluid in women varies from 5 to 200 milliliters, we found it in only 21% of the patients included in the study, and this proportion was not significantly related to hormonal treatment intake. Next, we analyzed the quality of the free peritoneal fluid and lavages obtained, which presented a cellular viability higher than 98%. Blood contamination is a major problem in peritoneal samples, which may be due to a rupture of the blood vessels during the surgical procedure or previous events, as a consequence of endometriotic lesions or as remnants of retrograde menstruation. Nevertheless, in all cases, blood contamination would alter the results obtained. We observed that 54% of the samples had good quality and sufficient cellularity to be used in biomedical research, while 40% were contaminated with blood, and 6% had low cellularity. The volume of saline solution used for the lavages positively influenced the number of total leukocytes and macrophages obtained from the samples. Therefore, the 10 milliliters previously recommended by the World Endometriosis Research Foundation may not be sufficient, since some of available leukocytes that could be used in biomedical research are being neglected, reducing the efficiency of the procedure. We also found that the total number of leukocytes and macrophages obtained with the same initial lavage volume was negatively correlated with the body mass index of the patients. This could be the result of a greater adhesion capacity of immune cells, a poor immune cell recruitment process, or a reduction in the mobility of the saline solution within the peritoneal cavity in patients with higher body mass index. Hence, this finding suggests that sample collection is less efficient in these patients. On the other hand, we found that the age of the patients did not affect the number of leukocytes or macrophages obtained from the samples. We present an optimized step-by-step procedure for peritoneal fluid and leukocyte collection in women with endometriosis. Our results showed that not all women with endometriosis have free fluid in the peritoneal cavity, and its presence was not significantly related to hormonal treatment intake. We also found that both lavage volume and body mass index affect the efficiency of cellular recovery from the samples. For this reason, in order to increase the efficiency of leukocyte collection from the samples, especially for those patients with higher body mass index, we propose increasing the lavage volume from 10 milliliters to at least 40 milliliters of sterile saline solution, and its mobilization for at least 30 seconds within the peritoneal cavity.